Good morning. Welcome to the Wilson Center. I'm Sarah Barnes, and I lead the Maternal Health Initiative here at the center. For those of you who are not familiar with the Wilson Center, it is a living memorial to President Woodrow Wilson, who is the only president who has received his PhD. The Maternal Health Initiative, as well as our co-sponsor, the Environmental Change and Security Program, or ECSP, both exist under the larger Global Risk and Resilience Program here at the Wilson Center. MHI focuses on ending preventable maternal mortality and navigating gender-based health issues globally, while ECSP centers its work on the intersection between environment, health, population, conflict, and security. It is always such a pleasure when our work collides and we get to collaborate and host a transdisciplinary discussion like today's on family planning in humanitarian settings. Welcome and thank you all to the panelists for being here today and also for Skyping in from Egypt, Nancy. It is a pleasure to have you here at the Wilson Center. I am grateful for the support from Save the Children, CARE, the International Rescue Committee, and FP 2020 that have made this event possible. I would like to give particular thanks to Chris Lindahl from Save the Children for coming to me with the idea for this event, and to my MHI team members, particularly Amanda King and Dikshita Ramanarayanan, and our great AV team for putting this event together. Thank you to our audience for being here today, and for all of you watching remotely for what I'm sure will be a very important conversation. At the close of our event today, there will be a Q&A period for our live audience. And for those watching the live webcast, you can submit questions on Twitter to our handle at Wilson_MHI, and we will get those questions to our moderator. That handle will also be on the back screen behind panelists throughout the event. And now it is my pleasure to introduce our moderator and to welcome back to the center, Gwen K. Young. Gwen is currently the Managing Director of the Global Emergency Response Coalition and a Distinguished Fellow at the Wilson Center. The Global Emergency Response Coalition is a life-saving humanitarian alliance made up of 8 leading US-based international aid organizations, including several of our panelist affiliations today. Prior to this, Gwen was the Director of the Global Women's Leadership Initiative and the Women in Public Service Project here at the Wilson Center. Please find Gwen's and all of our panelists' full bios outside of the room. Thank you again for coming, and I'll turn it over to Gwen.
Great, thank you, Sarah. And thank you to CARE, the IRC Save the Children Family Planning 2020. And thank you to all of you for being here this morning. Really excited to have this conversation, which is going to be incredibly rich. And I'm glad our conversation's spanning continents as well. So Nancy, welcome. I'm glad you're here on the video with us. As you all know, we're here today to talk about family planning in humanitarian settings. To talk about that, in addition to being a human right and a part of broader development goals, family planning saves lives, even in times of crisis. I'm going to give you a few stats just to help sort of set the stage here, right? 1 out of every 70 people in the world is in need of humanitarian assistance at this moment. And 1 in 4 people in that setting is a woman or girl of reproductive age. So this amounts to about 34 million women and girls that are displaced by natural disaster, war, or conflict, the variety of humanitarian settings in which we all deal with on a daily basis. These women live across 42 countries and are a uniquely vulnerable population. First, incidents of rape and other forms of gender-based violence increase during times of crisis, affecting women and girls more acutely. The rates are already high. And already high rates of unplanned pregnancies, unsafe abortion, and maternal death in many of these settings are magnified during times of crisis. Also during times of crisis, as we all know, health systems become severely strained, and skilled care is often out of reach. This results in figures like 60% of maternal deaths taking place in countries affected by conflict, displacement, or natural disasters. But during these times of humanitarian crisis is exactly when family planning is critical. And as emergency situation and conflicts continue to unfold, for those of you who don't know, the average rate of a humanitarian sort of crisis right now is about 9 years, right? So these can be very short and can be very long time periods. More must be done to provide quality, comprehensive family planning information, services, and supplies to women and girls in humanitarian settings. So I'm going to turn it over to the expert to discuss the types of family planning programming delivered in the various types of contexts, the lessons learned, and the best practices. I'll introduce them quickly, and then we're going to turn them over. To my left is Seema Manohar, who's the Emergency Response Specialist for Sexual and Reproductive Health and Rights with CARE's International Rapid Response Team, and from On the Moment based in Liberia. Next to her is Erin Wheeler, who is the Contraception and Abortion Care Advisor at the International Rescue Committee. Jennifer Schlecht is the Senior Advisor for Emergency Preparedness and Response at Family Planning 2020. And Nancy Ibrahim is the Reproductive Health Advisor in Emergencies at Save the Children. Seema, I'm going to turn it over to you to give us a sort of an overview of the work in the DRC.
Right. Thanks, Gwen, and good morning, everyone. Today, I'll be presenting on behalf of my colleague, Rausa Volalona, who is the program manager with CARE International in the DRC. She couldn't make it in time for this event, but I do want to acknowledge her and her team who do incredible work under very difficult circumstances. Okay, so today I will be sharing about CARE's work in sexual and reproductive health. We'll continue to call it SRH, in the Democratic Republic of Congo, which is DRC. Be ready for all the acronyms. And I'll specifically be talking about the program we refer to as Supporting Access to Family Planning and Post-Abortion Care in Crisis Setting, also known as SAFPAC. Is anyone counting the number of acronyms we're going to cover? So just as a background, the RAISE Initiative and its partners, CARE International, the International Rescue Committee, and Save the Children, so all the panelists here today, began supporting the Ministry of Health in the DRC to improve sexual and reproductive health services in 2007. In 2011, the program intensified its focus to improve access to post-abortion care and modern contraceptive services. The key objective is to deliver high-quality, comprehensive family planning with an emphasis on long-acting reversible methods, safe abortion, and post-abortion care services that do not discriminate based on age, marital status, or parity. The core programming elements are consistent across the three organizations. We work with the Ministry of Health, public sector facilities, and their providers. The projects include, but are not limited to, competency-based training for providers, supportive supervision, community engagement, supply chain strengthening to ensure all contraceptive methods are available, and the use of participatory data collection for decision-making. CARE specifically works in North Kivu, and to give you a context of the area, nearly 2 decades of war in eastern DRC have resulted in the displacement of about 2.2 million people, and the majority of them are in North Kivu. So it's a chronic, intermittent conflict marked by cycles of displacement and returns. The DRC ranks 176 of 188 in the Human Development Index as of 2018. It has a severely compromised health system. Are those pictures clear? Can you see them in the back? Okay, great. And it receives substantial foreign aid and has a large UN and NGO presence. So CARE takes an ecological approach to engaging individuals, health providers, communities, changing social norms, health system strengthening, and pursuing advocacy to create an enabling environment for sexual and reproductive health services. So as you can see in this slide, we work through the various determinants to influence SRH behaviors and services to enable women and girls to exercise their SRH rights and to avail of those services. CARE specifically uses a community-driven approach for decision-making and accountability. It's a three-part process. So the first are community facilitators who collect feedback and complaints from community members, and specifically from women and girls. This feedback includes experiences at the health facilities, any myths and concerns they have about contraceptive methods, challenges with the providers, or any cost barriers. The purpose of recording this information is to ensure that women and girls' lived realities are fed back to the providers, and any modification to the health facilities are made to really meet their needs. The second are the health providers who register new and continuing family planning users, the methods they select, any trends that they observe. They also collect information through exit interviews, hotlines, customer feedback boxes, and so on. CARE conducts monthly supportive supervision visits, and following these visits, community facilitators, the healthcare providers, and the CARE staff meet to discuss monthly data from the facility and the community. So a primary focus of this interface meeting is elevating each anonymous complaint and finding solutions to barriers that inhibit women and girls from getting the services they need. So those are some pictures of those interface meetings. Feedback from the interface meetings leads to action planning, which is monitored by the three parties, so the community, the health providers, and CARE, and provides an opportunity to really hold the providers as well as CARE accountable to our beneficiaries. Okay, so shifting gears a little bit to talk about the government involvement. At the third International Conference on Family Planning in Addis in 2013, the DRC government committed to increasing the contraceptive prevalence rate from 7% to 19% and to provide 2.1 million women and girls with contraception by 2020, so by next year. In response to this, the government in DRC launched the first permanent multi-sectoral technical committee for family planning, also known as the Family Planning Committee, much easier to remember. And these are the group of individuals who are pictured on the left. They are a national platform that builds commitment across government sectors, donors, international partners to increase the utilization of family planning services. And then CARE helped to mirror this national committee at the provincial level in North Kivu. And in March 2018, the governor of the North Kivu province declared family planning to be a priority of the provincial government. Since then, the committee has successfully advocated for a budget line of $77,000 in the 2018 provincial budget to purchase contraceptives and supplies. That is a substantial amount given the context. We also support local government health facilities through routine joint supportive supervision visits. So CARE and local government representatives would do supportive supervision visits to the health facilities and have quarterly stakeholder meetings to analyze program data together for continuous program improvement. We support provincial and district government health authorities to prepare for emergencies, to build capacity on the Minimum Initial Services Package, acronym number 5, MISP. What is the MISP? The MISP is a series of crucial life-saving actions required to respond to reproductive health needs in every humanitarian emergency. The MISP is not just about kits and equipment and supplies. It includes a set of activities that need to be implemented in a coordinated way by appropriately trained staff. And so incorporating the MISP in contingency plans and quantifying and pre-positioning the kids is an important part of the preparedness process. So Ooh, okay. So given our sustained presence in North Kivu, which still remains in a chronic crisis state, we were able to pivot from comprehensive sexual and reproductive health services to rapidly responding to a new emergency in the Kasai region. So in the Kasai region in mid-2016, there was armed conflict that broke out, and that conflict triggered displacement of more than 1.4 million people, widespread sexual and gender-based violence, a cholera outbreak, and food insecurity. So there was a lot going on. In terms of services, you can see the list of services that CARE provided. But an important thing to note here is that because CARE had an ongoing and mature sexual and reproductive health program with experienced SRH program managers, trainers, and clinical providers, this allowed experienced staff to support the emergency intervention in Kasai and initiate high-quality services with minimal outside help. Also to note, with the family planning, there were only short-term methods available prior to the conflict, and currently there are both long-term and short-term methods, as well as adolescents were captured in terms of new users, and 6% of adolescents are new family planning users. Out of the 6%, 66% of adolescents ask for long-term acting methods. I'm almost there, I promise. So just based on CARE's experience again in North Kivu, we were able to establish a family planning committee. And to date, this committee has quantified the amount and cost of contraceptive needs in Kasai. It's organized a provincial MOH officials training on the minimum initial service package. And it's established thematic groups to discuss specific issues such as contraceptive security. Okay. So just to conclude, some key points I'd like to leave you with. One, rights-based sexual reproductive health services, including family planning and post-abortion care, safe abortion care, is completely achievable in fragile humanitarian settings. And my colleagues from SAVE and IRC will also demonstrate that it's possible in a variety of humanitarian settings. Two, for comprehensive SRH services to be provided, it is essential that policymakers, local government authorities, the communities themselves, and health providers are involved in the planning for services, the implementation of the services, and eventually the accountability of those services. And finally, the third point is integrating SRH in emergency planning and relying on local resources that exist in the country allow for a swift and agile response to any new emergency. And it's really a testimony that resources and capacities can be sustained even in a fragile setting. Thank you for listening.
Wonderful, Seema. So this was a great overview, and I liked the really good discussion about the role of the national, the provincial, and the communities, and how you're doing that feedback loop in the DRC, which is incredibly important, and this sort of protracted crisis, and the importance of having the already on-the-ground programming and able to respond rapidly to your last point. So I think that's fantastic. So let's move on to a sort of migration crisis, if you will, and move on to Erin Wheeler, who's going to speak about Colombia.
Hi, everyone. So I'm Erin Wheeler from the International Rescue Committee, and today I'm going to tell you a little bit about our family planning programs in crisis, and more specifically about a response we led in response to the Venezuelan refugee crisis in Colombia. There we go. Okay. So for those of you who aren't aware, the International Rescue Committee is a humanitarian response organization that responds to the needs of people affected by crisis across the humanitarian development continuum, including preparedness, acute emergency response, recovery, and in the U.S., resettlement. We have multi-sector programs in more than 40 crisis-affected countries around the world. So in our global strategy that drives our work in humanitarian response, we have made specific commitments to achieving key health outcomes for women and girls. And these include preventing unintended pregnancy by providing comprehensive contraception. Furthermore, the IRC has committed to narrowing the gender gap across all programming and is striving to be a feminist organization, both of which require that we invest in family planning for women and girls affected by crisis. So this video does a better job than I ever could at demonstrating the importance of IRC's work in family planning in humanitarian settings.
A South Sudanese who has experienced serious effects of war. It has side effects on women and our children.
¿Cómo es la vida en Venezuela ahora?
No es comparado como era antes. Ahora no sabemos si el día de mañana vamos a comer o no.
Ta rasu ma a zafin guduwa, kuma akwai wanda suka aihu a layin guduwa. Ko na aihu alhamdulillah. 8 ne, ɗaya ya rasu 7 akwai. Kuma a duniyarmu na yanzu nan, rayuwarmu na yanzu nan, ba ko da yake akwai Allah, amma duk da haka ya kamata ka ɗan futa.
Oops. I've seen that video so many times and it always makes me tear up. So the bread and butter of IRC's health programming is implementing primary healthcare programs in crisis settings and fragile states. And we aim to integrate family planning in all of our primary healthcare responses for all of the reasons well described on this video. And last year, we had family planning programs in 19 countries. Most of these programs also include post-abortion care, and we support safe abortion care in 8 country programs. The IRC has implemented our flagship family planning program in acute and protracted crises, which is funded by the large anonymous donor since 2011. We call it CONCASE, but CARE rather calls it SAFPAC, more acronym soup. So we have supported access to contraception and abortion care in Chad, DRC, Pakistan, and Myanmar since 2011, and we've also supported 22 SRH responses in acute emergencies. In these acute emergencies, the IRC supports the MISP, which Seema so eloquently described, and is the global standard for SRH emergency response, and it includes both comprehensive contraceptive methods as well as abortion care. So today, I'm going to briefly share our experience implementing an SRH program in response to the Venezuelan refugee crisis in Colombia, where economic collapse in Venezuela has led to an exodus of the population, among whom nearly half are in Colombia. Though Colombia has a strong health system, it's not equipped to deal with the complex needs of the large numbers of refugees. The insurance-based system of healthcare financing, which is not entirely different from our system here in the US, leaves refugees and migrants without coverage except for life-saving care. Furthermore, there's a lot of xenophobia and reluctance to provide more services to refugees out of fear that it will increase the number of Venezuelans migrating to Colombia. As a result, most refugees lack access to essential health services, including family planning. The IRC is working to increase access to a range of essential services, including family planning, in Cúcuta on the border with Venezuela, as well as in Medellin. The IRC first launched in 2018 in Cúcuta on the border, which is really the front line of the crisis. We initially experienced challenges working within the public health system in partnership with the local government because they were really quite overwhelmed with the crisis, but also seemed to lack the political will to partner with an international humanitarian organization to serve this population. The immense and immediate needs of the Venezuelan population led us to open a comprehensive care center, which is essentially a one-stop shop for protection, health, and cash programming. We provide the full range of contraceptive methods as well as medication abortion, in addition to a suite of other services. And we do partner with local laboratories and pharmacies to ensure necessary and coordinated care. And we also partner with Pro Familia, who is the local IPPF affiliate, to whom we refer abortion cases beyond 13 weeks. The IRC's program in Medellin, which launched just this summer, is actually quite different, and I think provides an interesting counterpoint to the programming we implement in Cúcuta. So Medellin is a larger and more progressive city with a stronger social welfare program, and the government contractor who provides public health services had already begun to offer limited care to refugees. However, most of this was antenatal care, which is notably not part of the MISP. Okay, so the care that they were providing was not in line with the essential package of services that we prioritize in humanitarian settings. They did not have the resources to offer family planning, and it really wasn't prioritized. And furthermore, many refugees did not know how to navigate the public health system, which resulted in their reluctance to seek even the care that was available. After initial discussions with Metro Salud, which is the government contracting agency, about the MISP and the needs we were seeing among this population, we formed a partnership with them to improve access to sexual and reproductive health services for Venezuelan refugees, including contraception, abortion, and STI testing and treatment. We now offer coordinated care at 2 Metro Salud facilities in which refugees can receive free SRH services, as well as, importantly, linkages to other services provided by the IRC, such as protection and gender-based violence case management. This graph shows you the number of Venezuelan women and girls starting contraceptive methods at IRC-supported facilities in both locations. The more gradual increase in Cúcuta was due to an early shortage of staff in the program, and we saw numbers significantly increase once we hired a dedicated family planning nurse. 1,783 Venezuelan clients have started contraception at IRC-supported facilities since October 2018. Interestingly, you'll see that half of our clients accepted LARCs, long-acting reversible contraceptive methods, which is actually quite typical in our emergency response programs where we provide good quality family planning services. This tends to be true in DRC, Chad, Pakistan, where we see at least 50% of our clients choosing long-acting reversible methods, and in some places actually many more. And I think the partners would also share this experience as well. Also interestingly, most of our clients are under 25, which is kind of exciting in that we know that we're serving younger women, but we're also trying to understand the factors that are driving this age distribution so we can make sure that all women and girls who need it have access. We provided or supported 81 clients to receive safe abortion care since 2018. And we're also, as I mentioned, referring to Pro Familia for cases beyond 13 weeks. And initially, we referred some additional clients before our abortion care services were up and running in Cúcuta. I will say the provision of SAC has been the safe abortion care, more acronyms, has been a bit more challenging in Medellin in partnership with Metro Salud, though their standard of care is to offer safe abortion care up to 20 weeks. But we're actually finding some providers a bit reluctant to offer the service. We're seeing conscientious objections, but also they require hospitalization for even first trimester abortion, which actually has been dramatically increasing our costs. And so we're in discussion with their leadership about how to improve the care they provide, including improving staff attitudes and ensuring access without delay. In the meantime, we are documenting these delays. And interestingly, our protection team is providing support, including food assistance, to our safe abortion care clients during their hospital stay. So what have we learned in Colombia in similar contexts? So we really can't assume that refugee and displaced women and girls have access to family planning just because they reside in a place with a strong health system. In fact, in IRC's experience, they often don't. But the barriers that these women and girls face may be different than those they face in a low-income crisis setting. When the barriers are different, the solutions need to be too. At the same time, humanitarian agencies can't go in thinking we know more than the local organizations and governments we aim to partner with. We need to form meaningful partnerships that leverage the expertise of humanitarian and local organizations to meet the complex needs of women and girls in crises in the most efficient way. Even within the same crisis in Colombia, the solutions we found to alleviate barriers to family planning access were quite different in different cities, based on the experience and willingness of the local actors there. And this is one of our intake offices in Medellin. Thank you very much.
Thank you, Erin. I just wanted to ask a couple quick follow-up questions. So you said right at the beginning, there was the lack of political will and kind of reluctance to partner with a large international humanitarian organization. Can you specify a little bit more about why you think that was, or where that came from?
Sure. I mean, I think that the local health systems in Cúcuta and Medellin are different. In Medellin, it's just stronger. And again, they had a more of a social welfare system already than what was there in Cúcuta. But I also think Cúcuta being right on the front line of the crisis was really kind of in the thick of it. And there was this concern that if we provide more services, we will be encouraging people to come. Mm-hmm. So I think it was about capacity and resources on their side, as well as perhaps some attitudinal issues. I know that a number of partners are certainly working in this area, and it's been a complex challenge. So I think that there are still, of course, opportunities. It's just that it was a very different context. And we also was earlier in the context when we were launching the program when things were quite chaotic. And so I think that also kind of contributed to the challenge and also the need to just get services there for people because the needs were so acute.
Everything is challenging right at that particular moment. What I liked is you talked a lot about kind of the local capacity in the specific groups, whether it was Metro Salud or Pro Familia and so forth. What is that capacity like? Did you find it sort of relatively strong comparatively?
In terms of health services, yes. I mean, the capacity is quite strong. I mean, in a lot of the middle income countries in which we intervene, we do see it's a very regulated system, which is something we often see, which sometimes can pose barriers to services access and task shifting, sort of like we're seeing with the hospitalizations for safe abortion care. And I think what the IRC brings is this ability and capacity to serve the specific needs of displaced populations. We have these multi-sectoral programs that are responding to the complex needs, whereas in a health clinic, sure, they can insert an IUD. That's not really the issue, but serving those holistic needs and then again, helping to navigate the health system, which is really quite complex.
And the regulations and so forth to be able to do so. Yeah. Wonderful. Thank you so much. We are going to turn it over right now to Nancy, who's going to talk about the ongoing conflict in Syria. Nancy, you have the stage.
Thank you, Gwen. Okay. I'm sorry, I don't see the screen. So is the presentation on or not yet?
Yes.
Okay. So thank you for the opportunity to present about our work today and facilitating me joining remotely for this event. Today, I'm going to speak about our program in Northwest Syria. And as Seema has explained all the acronyms, our program is FPPAC, Family Planning and Post-Abortion Care. So first slide, please. So I will give an overview of the Syrian context. Entering its 8th year, the war in Syria is still ongoing, and with more than half of the population has been displaced internally or outside of Syria. The humanitarian crisis is affecting around 17 million, leaving them in need for assistance. And in the absence of a political solution, the crises are likely to persist. Here is some of the estimated numbers of the affected population. So total affected population is around 11.7 million. Syrian refugees is around 5.6 million, mainly in Turkey, Jordan, and Egypt. Women of reproductive age is 2.9 million in Syria and around 1.4 million among Syrian refugees. Pregnant women in Syria are around 280,000, and in Syria, and in the Syrian refugees is around 130,000. Estimates of pregnancies that will end in miscarriages or unsafe abortion in the next 3 months is around 14,000 inside Syria and 6,500 among Syrian refugees. Next slide, please. So there is actually limited data about the current situation inside Syria, but with the data we have, there are worrying trends. So you can see on the graph on the left, the maternal mortality ratio has increased since the beginning of the war. And if you took another look to the graph on the right, you will see also a significant increase in the percent of population living in poverty. With reports that the Syrian lira lost around 40% of its value this year only, which leads and reflects to the prices of the essential goods inside Syria. Next slide, please. So a brief about our program in Syria. We are working in Syria since June 2016. Our program working in 8 facilities in northwest Syria, mainly in Idlib and Aleppo governorates. Our partners are Syria Relief, Shafaq, and Idlib and Aleppo governorates. Since the summer, the government of Syria is advancing in northwest pockets, and this leading to an estimate of 600,000 IDPs. And with the advancement of the troops, more displacement is expected to take place. And throughout the past period, there was recurrent airstrikes, which affected a lot of civilians and children. On the 3rd of October, one of our supported facility got hit, and we had several injuries among patients and a doctor. Next slide, please. So this graph is showing the trends for the uptake of family planning within the new clients in our supported facilities. Since the start of the program till August this year, we have more than 19,000 new clients. Around 36% of the clients have chosen a long-term acting method, mainly intrauterine device. And the most popular method, as you can see, is pills followed by IUD and injectable. Pills are still preferred by women in Syria as it is the most popular, convenient, and accessible and easy to administer. IUD is becoming a very good choice as being long-term, especially with the recurrent displacement and the security situation. So it would be hard for a woman to go to the facility each month to get the pills or injectables. Implants has been also introduced this year in our supported facilities, and we have been seeing a very good uptake of this method as a long-term option also. Next slide, please. So this is the results of a client exit interview that we have conducted last year in our supported facilities, and you would see that most of the respondents found the services satisfactory. So around 74% were very satisfied and 25% were somewhat satisfied. Next slide, please. So our program components, we are actually working among various interventions. So the program is focusing on working with partners, our partner Syria Relief currently, and we also coordinate and collaborate with local partners, UN agencies, the RH working group, to ensure better coordination and collaboration among different stakeholders. We support the facilities with commodities and supplies and some minor rehabilitations. We also give technical support to service providers to ensure that quality services are being provided in our supported facilities. We have a community mobilization strategy where our community health team works on delivering health awareness messages about reproductive health and family planning and post-abortion care, and also refer cases to the health facilities to get services. And we have also client tracking system where they would track any clients that didn't come back for a follow-up and try to ensure that she can get service. Next slide, please. We also work on remote support and capacity building. So in addition to face-to-face trainings, we provide a range of technical trainings for the partners covering family planning and post-abortion care. Sometimes we have to do remote support either due to security issues in northwest Syria, we have no access, and also even when we try to do the trainings in Turkey, sometimes the service providers cannot get the security clearance to cross the borders. So we had to rely on innovative ideas to ensure that the team can provide quality services. We have trainings that is available online and offline. We provide remote Skype video trainings for the service providers in Northwest Syria. And also we have regular technical meetings with the partner staff to discuss data and answer any technical questions that they might have. The photo that we have in this slide is from our last face-to-face training. It was done in April this year in Antakya. And actually, I think it's very small, but the service provider is presenting an exercise from the training, and she was actually 9 months pregnant when we arrived to Antakya, and she was 37 weeks pregnant, and I was amazed with the commitment and the energy that they have just to come have the training. And she actually delivered 2 days just after the training, but they actually are the real heroes here on the ground. Next slide, please. We also provide supportive supervision and monitoring. So working with our partners, we provide supportive supervision and monitoring systems. The clinical supervisor provides on-job training and coaching for service providers using tools and checklists for monitoring and evaluating the clinical procedures that is conducted by the service provider. Then after that, the clinical supervisor would tailor the supervision visit according to the needs of the service provider and focus on the areas that would need further on-job training and coaching. So we also provide follow-up of the trainee's performance after the training. We have a tablet supervision module where the supervisor can track the performance of each trainee on each procedure, and then would provide assisted training, or on-job training or coaching accordingly. We have also regular data check and review and discussion of the data trend with the partner team, where we plan our action plan and capacity building plans according to their needs. Next slide, please. So I wanted to highlight also our other responses for Syrian refugees. So for example, as we always work towards sustainability and focus on the capacity building of the national systems, in Egypt, we are working with UNHCR and the Ministry of Health to ensure that the refugees can access health services through the primary care units and can be treated as Egyptians inside the facilities. We support technical capacity of the Ministry of Health through capacity building for service providers and management staff at the district and governorate level. We also support central level MOH through supportive supervision and health information system. We increase the capacity of the facilities through equipments and supplies and procurements. We also established 2 training centers inside the Ministry of Health and invested in training master trainers so that we can ensure the sustainability of the quality training that has been done to be then rolled out with the Ministry of Health master trainers for the rest of the facilities and within Egypt. So I think this marks the end of my presentation today. And thank you for the opportunity, and I'm looking forward to the discussion.
Thank you, Nancy. I wanted to follow up a little bit. You're doing within Syria such a large amount of community outreach and mobilization and follow-up. What were some of the challenges, or what were some of the opportunities? What was the level of knowledge about sort of family planning generally? We saw the maternal health rates sort of spike due to the conflict, which is fair. But what does that look like? What are the challenges, or what are the opportunities in doing all of that sort of mobilization and follow-up and training and outreach?
Yes, it's really a new concept for most of the families, and their knowledge about family planning is very, very minimal. But actually, with the displacement and the acute conflict, they became more open to discuss these issues, to explore new options or things that they wouldn't think about. It is really difficult to reach out for some of the population inside Syria because of the constant displacement. So, and there is no address system in Syria. So we are only communicating with them with phone numbers usually, and it's changing. We usually cannot reach out for our beneficiaries when they drop the follow-up, but actually the teams are doing a great job on the ground. So they reach out for a huge amount of people, and they are very passionate about family planning. We are seeing an increasing trend in the numbers of beneficiaries, and it's all about their work. So what we are doing in our community mobilization strategy in Syria, that we are integrating this among all our health messages. So they are not talking only about family planning. It's a comprehensive package of services that are being provided inside the facility. And I think this had made the big difference, that you are not talking only about family planning, you are talking about a lot of other services that the family actually can come and benefit from. And this is the starting point where you can talk about family planning specifically and the reasons behind not using a method or any misconception they have.
Yeah, it's the integration into primary care and healthcare messages. Jennifer, do you want to, sorry, Nancy, did you want to say something else?
No, thank you.
Jennifer, do you want to kind of wrap this up looking forward? Yeah, you can stay there.
So thank you. So my name is Jennifer Schlecht, and I'm from FP 2020. I serve as the Senior Advisor on Emergency Preparedness and Response. And so as you would guess, with a global partnership that drives family planning progress forward through country-level commitments, we work in quite a different level than the implementing partners that we have here on the stage. So what I was thinking is to provide a little bit of reflection on where we've come and how far we've come in family planning and humanitarian contexts, and reflect on where we still need to go, and then how this partnership potentially fits into that space. So I think for many of us working on SRH in this space, with ICPD approaching, there's been a lot of reflection and pause that comes as we look at 25 years and what has been achieved. And I was reflecting on one of the most seminal reproductive health reports that came out 25 years ago, which was reassessing priorities. And at that time, family planning was quite literally unavailable in refugee contexts. So what we were seeing was that family sizes were observed to be unusually high. Women in refugee context, even with high obstetric risk, were observed to have very close birth intervals. And there was a near exclusive emphasis on MCH and the training of traditional birth attendants. It was observed that family planning needs of the refugee population had been totally ignored, and that was a report from many of the implementing agencies at that time. So when we imagine the women that you've seen in these videos, the context that we work in, where health systems are quite weak, when there is a desire to prevent or delay pregnancy, to have absolutely no access to family planning, place them in such a vulnerable circumstance. So I really applaud the work that we've seen and that was presented on the stage today by these critical partners. The past decade has truly provided quite a bit of momentum with regard to family planning and humanitarian contexts. And it is through the sustained attention and predictable funding that has been made available to this particular issue. It's provided us with groundbreaking knowledge around need, demand, feasibility for family planning. And these agencies that are before us have really provided us with this groundswell of information that many of us are building on today. Family planning is also now established as a minimum standard of care in emergency contexts. This was not always the case. It is now part of this minimum initial service package that was acknowledged earlier, which really helps to secure some of the progress that has been made in the last decade from the work that's been invested in. So what we are forgetting, however, is that many of these efforts are still pilot projects, or they are efforts within specific organizations. And so millions of women and adolescent girls are yet to be reached by these important efforts. So there's a real need to look at scale. And at FP 2020, obviously, as well as among many partners, this is a real interest for us in entering this space. We've been really proud over the past couple of years to build partnerships with the Interagency Working Group for Reproductive Health to think about what this space needs and how we can better support partners that are working on this. Within the partnership, we see this as a critical need, and we are incredibly motivated to understand and engage on this issue. The world is increasingly unstable. We see conflict, climate crisis, and displacement are the new operating environment that we're working with, and it's critical to provide attention and support to the countries that are dealing with these circumstances. It's also critical to provide that attention because our global development and FP goals cannot be achieved without that attention. So FP actors that are working in countries are increasingly aware of the need to prepare for and respond to these emergencies if we want to ensure the continuity of FP services that are available. The intersects between crisis, risk, and resilience are also closely linked to our family planning progress. So within our FP 2020 countries, 30 of the 46 countries that have made commitments are at high risk or very high risk of disasters, according to the Informed Risk Index. Additionally, 14 of our FP 2020 focus countries with the lowest modern contraceptive prevalence rates are fragile contexts. This helps to highlight that critical overlap between development progress, conflict, and our family planning goals. So within the Secretariat, we've worked over the past couple of years to build our capacity to provide support on this issue, and we'd love to see many of our countries more systemically focus on preparedness, response, and recovery as they focus on family planning. We see a role at both the global level to maintain advocacy. Unfortunately, we do see that when advocacy is not maintained, many of us slide back with regard to any of the gender issues, sexual reproductive health, and family planning, so that sustained attention is critical. And then we see working with our FP 2020 commitment-making countries to help them understand their risk and support their efforts towards resilience and preparedness. We've had wonderful response from the countries that we have engaged with. This is now a critical part of all of our focal point workshops. We talk about risk, we talk about resilience, we talk about climate crisis in these contexts, and we've had quite a few countries express that they are pleased that this is now part of the dialogue. In countries such as Mali, they now come to us and ask for support as they are considering their extended reach to conflict-affected populations. Afghanistan, working on their integrating the MISP training in their routine RMN-ACH training. When we've had commitments coming from Solomon Islands, out of the Asia Focal Point workshop just this last year, we were thrilled to see that they put disaster preparedness as a cornerstone to many of their action plans. And with countries such as CAR, Chad, DRC, as part of the partnership, really looking at what this work looks like in contexts that are cyclically affected by crisis and conflict becomes really critical. So where does this take us? We are now, as you would guess, from FP 2020 at a critical moment of reflection and looking forward. And this provides us an exciting moment to both reflect on what has worked and what is needed going forward with regard to the partnership. The humanitarian community through the IWAG showed up at the London Summit in a very strong way in 2017, and the door as a result is very open to considering humanitarian contexts within the global partnership going forward. There is certainly no question that the partnership will engage with humanitarian partners as we move forward, and we really hope to build on the momentum that these new actors can bring by helping to solve some of the more intractable problems that countries affected by crisis and affected by crisis risk face. So We look to all of you to help us shape the partnership going forward, and certainly to help us understand some of the intractable challenges, as well as how to bring partners across diverse sectors and working on diverse issues can come to the table to improve the outcomes for women and girls affected by crisis. So the time is now to accelerate action, and we look forward to collaborating with partners to map out how to best take the learning from these projects, as well as many others, and how to take those forward. I'd just like us to now return to the images that were presented through the slides and through the presentations, because these are the women that we are meant to serve. These are the women that we owe these services to, and certainly in crisis, they should have them. So thank you.
Great, thank you. That leaves us, Jennifer, with kind of one of the interesting questions. A couple of you talked about when you, I'll say, started family planning and sort of the crisis situation, that there are already other programming on the ground. And I want to talk a little bit about that continuum. How important is that? And kind of where is your organization, or where are some of your projects on the ground in that? It sounds like making the case for it being important, we're kind of there. But how is that in integrating in other programming? And then that comes back actually to Jennifer, your point about sort of preparedness. I don't know. Who would like to start? Seema?
I think, is this on? Sorry. Can you hear me? Okay. So I think as I shared in the presentation, it took a long time for the work and for the platforms to be established in North Kivu. But then having that in place allowed us to so quickly mobilize for that conflict in Kasai. And if that were to happen in another region, in another province, we would be able to very quickly mobilize resources. Whether it's having the trained providers or having the contraceptives in place, having also this government commitment, which obviously is huge. But it does depend on a variety of factors. It depends on commodity security in the country. So, for example, in Yemen, the ports of entry and whether those are secure sites when commodities come in, and whether those can be distributed, and what is the security around those sites to be able to do that. It definitely, having the trained providers. I think it was Nancy's presentation that showed. Oh, I'm sorry. Was it Nancy or Erin that where you had the the low uptake of family planning, and then hiring a family planning nurse then increase that uptake. And so, it cannot be emphasized enough on having trained personnel and what it takes to get there to have that resource. So it's definitely different parts of that coming together, and it does take time, and it looks different in every context in every region. But that's really why we keep emphasizing that having the thought and then the movement towards preparedness is essential.
Yeah, and Erin, maybe that it's interesting to talk about kind of that staffing and having the right people on the ground, and then not to put you on the spot, but the new sort of feminist agenda at the IRC and how that cuts across not just sort of family planning, but the whole package of services and sort of team buy-in to being able to include that.
Yeah, sure. And, just to complement what Seema was saying around the kind of time and effort that it's taken for us for these programs to really take root on the ground. I mean, we love presenting what we consider to be quite impressive results and in very challenging environments. But it's worth noting that it did take us a while as humanitarian organizations to really kind of put together all of the necessary ingredients to achieve this in places like Eastern Congo, Northwest Pakistan, Syria. It's been since 2011. And I think there was a large amount of investment that made that possible. But that investment also makes scale quite challenging because it is expensive. And so I think what we really I think where we need to go next, perhaps, is to use evidence to better identify the right package and dose of interventions in the most cost-effective way to actually deliver, to build that capacity more quickly at a larger scale. And, you know, in terms of this preparedness, you know, Jen and I and a number of partners have been having a lot of conversations about this. And, you know, I think in fragile states in particular with such weak health systems, you can't look at preparedness without having it be integrated within really strong health system strengthening efforts because they're really one and the same. You know, that resilience is kind of part of the broader package. And, you know, just to echo Seema's point around supply chain being a huge challenge that we need to crack in these complex environments. And again, this issue of provider competency. I mean, the investment these partners have made in providing quality care is enormous, both in terms of money and in terms of time. And so how can we do that more efficiently? And, you know, I think you know, in terms of IRC being a feminist organization, I think it's definitely related to making these services a priority based on the express needs of women and girls, but also just recognizing that women and girls face different and systematic barriers across the world and in crisis settings. And we have a responsibility as a humanitarian organization to address those very specific needs that women and girls have, because it really is driving the broader vulnerability in this context. And so family planning is certainly a critical part of that, but we need to look at it in all of the programming that we do.
I want to bring Nancy, I want to bring you in on one Erin's point about, and you said a lot about sort of the heroes on the front line, the trained staff, the people on the ground, both in Egypt and Syria, and the willingness to both put in the time, the training, the follow-up, and the energy, and talk a little bit about how important that is to the success of, you know, working with the communities and proving that this can be done.
I think it's an integral part of our response. You cannot just invest in doing trainings and without the follow-up or the supervision of the after training, because we see almost like uptake of knowledge around 20 to 30%, but with the follow-up and on-job training, coaching, and the supervision, we can actually see a tremendous change in the knowledge uptake and the performance of the service providers. So it should be like an part of our capacity building approaches. We cannot do trainings without investing in supervision and follow-up after the trainings, because it really do show a change, and it is part of building the capacity of the system. So you have to have this kind of whole system throughout the spectrum for capacity building.
And I want to bring it back to, do we have the evidence base that it can be done? We saw some successful models today, and I want you all to jump in, but and we've been saying sort of since 2011, what do we have? I mean, do we have enough evidence base to say that this can be done? Because I want to move on to the scale, and part of the scale is having that evidence base or those best models to show. Where do we stand with that? And jump in.
Yeah, I mean, I think we've made an immense amount of progress as far as our research base, the research that's come out of the coalition of agencies that's working here to say the need, the demand, the feasibility. The piece that I feel that we get asked for that I think we still fall short on is the costing, especially as we push for investments on preparedness. So, you know, in the context where we work, you know, when you're working with country governments or our focal points, and we are talking about how important it is to ensure your health system is resilient, you point to generalist data to talk about how, you know, to sustain your development progress, this is a critical investment. But it's very hard for us still to say the cost of investing specifically in preparing your family planning programs and what cost what the benefit cost-wise that would be. So I think we still fall a bit short on that. And that is very hard data to get. And so I think we've been forced to work around it to some extent, because we do know ultimately it's a stronger health system that is our overall goal. But I think that from my perspective, that's one of the key data points that I think is still lacking.
Erin, Seema, what do you
Yeah,
agree?
Yeah, I mean, I think all of us covered in our presentation some of those good practices, right? Supportive supervision, engagement with the community, engagement with local governance. So I think those are those basic public health good practices that we've been able to demonstrate is possible in a fragile setting. And so they exist and they can be brought to scale. But the costing element is definitely still a juggle.
And I would also just add, acute settings, rapid onset crisis. I still think I would love to see better evidence on really, again, that right package of interventions to rapidly increase provider competency. What's the best and most cost-effective way to get the stuff on the ground, right? Because I think, again, it's, we, in theory, in the MISP, you're not supposed to be doing training, and yet a lot of us are because we have to. That you need providers to have competency. You need the stuff in order to deliver these services. And we're doing it and we know it's possible, but we need to be doing it more quickly. And so I think getting that, and again, it's really kind of granular data in terms of what is the right amount of time. Can we do just on the job training? Yep. Do we have to do the classroom-based piece? Can we do it in 3 days? Yep. Is it better to fly somebody in, or can we have a roster? I think there's all of those kinds of really detailed information that we need to be at our best at an acute onset situation.
Yeah, I was just talking to somebody last week who said, can't you all get together and just have the capacity of the community in a database somewhere so that when this happens, you can pull out the great people that are there and available. Want to talk about another thing before we sort of move on the other factors that scale. I think one thing that was a theme throughout, but I'd like to talk a little bit about, that is the role of the government. And it seemed in the presentations that it was relatively easy to get the government buy-in. And I know you're smiling, that's why I'm pulling this out a bit. It's critical, from what all of you are saying. How easy and how hard has that been to get government, both at the local level and at the national? Because as we know, in many cases, that political will is incredibly important, as is regulations or the knowledge of the healthcare system or the workers being willing to kind of participate in that.
I think, it seemed from the presentation about the DRC that there were definitely these commitments made. And as you know, commitments made and how they actually translate to tangible actions. And there is definitely that disconnect. But I think, again, DRC being the situation of a chronic crisis setting, we were able to build that up gradually and really as an international partner be able to push that at the provincial level. So it was a bit more easier for us to do it at the provincial level because there was the national level commitment, though DRC is a huge country. So it was, but having that national level backup really enabled us to push that both in North Kivu. And if you saw, that within 8 months of the Kasai conflict, we were able to replicate that family planning committee model. And, sometimes people say, well, that's just a committee of people, but it does, it does indicate momentum towards building, a government buy-in for something as family planning, which, just 20 years ago, we wouldn't even talk about that as a service. So to actually have a committee that dedicates resources is huge. But every context, every government situation, acute or chronic, it definitely takes time to build that government support.
Mm-hmm. Yeah, it's interesting, to think about all the work that FP 2020 and others have done, because all of these commitments that the national governments have made have really made it much easier to start this conversation with government partners at all levels. And I think the way we all work is really we want to be supporting our government partners to be doing this work, to be implementing. But the reality is that in most of the places that we work, the health systems are so weak that it requires really intensive health system accompaniment agreement, we like to call it, to make it happen. And I think that we have had the most success working with our local government partners at the district, at the provincial level, in terms of making this happen. And, as Seema was saying, those relationships are critical. In these programs that we've had running for 8 or 9 years and some of these protracted crises, we've built really strong relationships, and I'm constantly amazed at the commitment of our government partners. But then these larger health systems factors that seem so much bigger than what we can change is what kind of is kind of the foundation of some of the ongoing challenges that we face, especially just the health systems financing piece. I mean, we want to talk about scale, we want to talk about sustainability, even in some of these very fragile contexts. But the reality is a lot of times humanitarian development organizations are bringing all the money into the local health system. Whatever is being committed at the national level, we're not seeing at the health facilities. And so if we kind of pull that program out, even though the capacity is there, even if the commitment is there, it's really hard to sustain. And so I think those kinds of challenges are really what we need to be looking at addressing.
Yeah, and it's one often we weren't looking at 20 years ago, and there's always that humanitarian thing of the time frame, right? Jen, you wanted to jump in?
Yeah, I was just going to say, I think because FP 2020 is a country-led initiative, I think we see a lot of opportunity to work with governments at the point that they're willing to be worked with. So, and it's, I really do applaud the countries that have come forward with commitments to reach the hard to reach. This is an expensive endeavor. This is a very challenging endeavor. And I think that there's always an entry point. So governments want the best for their population. You want to ensure that when a crisis does occur, the people that had services before have them still. And so building the resilient health system, ensuring it's prepared, has really offered, I think, an entree into work with governments around crisis that has been very productive.
Nancy, I'm going to start with you on the next one. What is the role of, the question we all have to ask at all panels, whatever it has to do with, what is the role of technology? How has that helped? And I do want to start with Nancy because you're talking about a lot of remote stuff, and you're here on video as well, and I'm guessing we do a fair amount of that as much as you can. But I do want everyone to jump in on the role of technology because there's all these mobile phone apps and training apps and so forth. Nancy.
Yes, I think it facilitated a lot of our work because honestly, without technology, I couldn't reach our team in Northwest Syria because most of the time they are not accessible. So when we started working with Syria, we had to find this kind of innovative approaches because we need to be there, we need to train our providers, and it was easy because of technology. So we had this Skype video training where I actually conducted the whole training through Skype video. I am today in this meeting through technology. And we also invested in tablets to ensure that the supervision is being done systematically and the data and the trends are tracked so that we would be able to have more guided and evidence-based decisions and interventions through our programs. We have all the training materials on those tablets. Just whenever a service provider in a remote location, he can actually take an offline training module or go through the guidelines or check anything that he would like to increase his capacity in. So actually, it allowed us tremendously to reach out also for our beneficiaries where we are tracking clients. There is no other system other than smartphones. So WhatsApp groups and talking and Facebook. This is most of the methods that we are using to reach out for our clients and beneficiaries. So it definitely helped, especially in a situation like Syria. And I think that especially the young service providers like the way of interactive learning. So e-learning courses, e-learning modules, they are very passionate about it and they can actually do it by themselves. They don't need anyone to train them. So it really helped us to increase the capacity and reach out for our beneficiaries.
Yeah, I was just smiling when you said WhatsApp, Nancy, because the first question that you get asked when you get to the field is, what's your WhatsApp number? And so it is amazing, too, in a lot of these countries, just where mobile technology plays such a huge role. And also because it is an affordable medium of communication, a lot of our programs and beneficiaries really rely on mobile technology, as well as like mobile money, for example, is another, just another avenue available to us for paying of community health workers or, health providers. So we're definitely seeing, an improvement in using some of what may seem as basic technology, but it really makes a huge difference in communication, particularly.
Yeah, I think when employed strategically to solve a specific problem, it can be really great. And I think I personally have been lately most excited about opportunities to reach out to vulnerable groups using technology, such as adolescents, LGBTQIA, people who might not be accessing services in the, quote, formal health system. I think there's a lot of opportunities there. And I don't know if this counts as technology, but innovation maybe. But, anything that's like putting the product in women's hands, I think is really exciting in the humanitarian space, given all of the health systems challenges we're discussing. Sayana Press, we're talking a lot about safe self-management of abortion. There's apps for that too. Those things that make it easier, frankly, for us to get services to women are great. I will say, and I think everybody in this room understands and would acknowledge that at the end of the day, investments in the basics are really the most critical to get us there. But again, we need to be using these technologies strategically because it's the wave of the future, and there are a lot of really exciting opportunities.
And if I could just jump in and echo that final point of, technologies offer great tools, but I do think it's really important that we focus on key solutions to the challenges we face in these particular settings. And I know when I've worked on some technology solutions in the past, sometimes in these contexts, we don't have as reliable internet connection as we would hope, and that is still a very real challenge. And so it's a consideration, I think, when we think about certainly that type of technology.
Especially in a rapid onset crisis.
Mm-hmm. Yes.
And then you're stuck with all the
when
tools.
There's reasons why it gets shut off.
Yeah, so there's reasons why it gets shut off. So what will it take? I mean, this is the question. What will it take to take this to scale, right? And I think that brings in a group we haven't talked very much about. I think, Jennifer, you mentioned, and if I misquoted you, I apologize, the money's there, right? Or there's I think you said sustainable funding line, and there has been. What will it take to scale, and what is the role of the donors in that piece of it? And beyond simply more money, which is something we would all want, right? But what will it really take to take this to scale, to be able to really go, this is just what we do. When there's a rapid onset, when there's, a protracted, it's just part of the services, and we have all the tools, people, resources, supply chain figured out, all of that. What would it take to scale?
I'll jump in and tackle this the best I can, but there's a lot of thought that goes into this. So there's a lot of excitement about the term the nexus, and so I'm going to just have to throw this out here. So there is a great need for humanitarian actors in the response to have predictable and sustained funding for that response so that they can provide high quality of care, of family planning in that emergency moment, ideally to some extent in the preparedness phase and starting to link with actors, and then to help with the recovery. Many times the funding for the humanitarian responses can be quite narrow, forcing a difficult and troubled transition into and out of the emergency. And I think that's where we face a lot of the challenge. So when we think about how you reach women and girls affected by crisis at scale, one, we need to bring a lot of actors and partners to the table around the problem solving here. And I think a lot of this is done in that more stable moment in a high-risk context where you are working with governments, working with civil society organizations, working with donors that are willing to work in that country and bring in humanitarian actors and trying to figure out kind of the role play of how this is going to unfold in a crisis and who will do what and what are the coordination mechanisms and who will lead on family planning. That's the only way that I see that we're going to actually be able to provide that continuity of family planning across that the continuum of preparedness to response to recovery. And that is really, I think, as our world is becoming less stable, this is the challenge that is before us. And so I think more people that are working on preparedness, response, and recovery need to ensure the integration of family planning as a critical component within that. And then all the actors that are working on family planning can do better to collaborate.
You said the word coordination, which is always a challenge. Nancy, I see you nodding there, and I want to make sure you want to come in on what it will take to scale.
So I think we have a lot of models and interventions that are existing since we started working in 2011. But I think we need more investment in health strengthening of the systems itself. Maybe some fund to test and the most effective models, because yes, we have a lot of models, but we are not doing it consciously. Maybe we can focus on investing a little bit in what exactly the best practices or models that we can follow, and definitely coordination and collaboration. Just to deliver at scale, we need all the actors to be really committed in something like that.
Yeah, Jen was mentioning this cost question we get a lot, and specifically within that, I would love to know, so much of what we invest in early on is really just getting the basics present. And I do believe that's expensive in the places where we're working. That doesn't mean we should be doing that for 10 years in the same places, right? So what is that cost to really just launch a program, let's say at a district or provincial level, get the providers there, get the supplies there. So there really does need to be a large injection at the beginning. But then I think we need to be more innovative and flexible once that's there, to then start shifting that investment to the local partners and pull back a bit, but still have that accompaniment model, because I still think it's needed for a longer term. But I think that with that initial large investment, and then we can start to pull back, recognizing that donors don't want to fund that size of a program for 15 years, right? And then being more strategic about how we're working with local partners to gradually shift responsibility, which will in the long term save us money. And I think something that I've been thinking about a lot in fragile settings, conflict-prone places with very weak health systems, what are kind of our intermediate benchmarks of success? Knowing, I think we have an idea of our head of what a developed health system would look like, a strong health system would look like. But we know in many of these places we're not going to get there in the next 20 years. So, what should be our 3-year plan? What should be our 5-year plan? And I think we can put our heads together and do that. But again, it kind of gets back to Jen's point, like when we've got these cyclical 12-month projects that are kind of, the same thing every time, like rinse, repeat, it's really hard to think strategically in that way as a humanitarian community. And like you were saying earlier, in terms of the length of the crises that we're seeing, 9 years, 17 years in some cases, we really do need to have that space to be more strategic in order to make a real push forward in terms of development at scale in these places.
And I want to, but before you jump in, after this question, I do want to turn it over to the audience. So I want to prepare you all on video and in the room. And I want to pull in this piece. We've talked a lot about partnership with government and kind of partnership with other NGOs. But there's a whole bunch of other stakeholders on the ground, and part of this is behavioral change as well, right? But there's a whole bunch of other stakeholders on the ground, whether those are legal organizations or churches or schools. And can we bring in a little bit of how important that is, especially when you have these weak health systems, or in some places this sort of non-existent government to partner with? And I know I did a lot of work in SGBV, right? So you really had to bring in a whole holistic group of people, because we as the NGO couldn't do it all. I don't know if you want to jump in on that.
Yeah.
Speaking of Liberia.
Yeah, I mean, local partnerships, key, those relationships with communities just cannot be underestimated. And so there is a lot to say for the countries that all our agencies work in over these long periods of time is, building that community trust, engaging the community, really making them feel part of the process instead of just being the beneficiaries of the handouts. I think it's really critical to move away from that model, but to really include them in a way where they feel empowered and feel as part of the process, and essentially they are the ones who live there, who are impacted by the crisis, and will continue to be the resources long after, the international humanitarian agencies leave. So I think that is really critical. The community engagement component is really critical from day one. And just to touch a little bit about norms, because CARE definitely, engages in a lot of community dialogues with women and girls, and those dialogues around social and gender norms and how those can be transformed for positive impact and for access to sexual and reproductive health services. I think a very interesting just an interesting observation around norms and emergencies and acute emergencies is that norms have a way of changing in an acute setting, a little bit like how Nancy said in the Syria crisis, how there wasn't that uptake of family planning, but being in a situation led people to have different health behaviors and health seeking and different gender norms as well. So I think that they should be viewed as an opportunity and not only as a challenge for us to build these services, because they do. Their reality changes, and so norms change. And I think we have that space to engage them under the new norm space.
That's great. That seems like a great time to turn it over to all of you. And I'm going to take, just so you know, I'll probably take 2 or 3 questions, and then we'll sort of turn it over. And I encourage all of you on the screen and on the stage, please, to just kind of jump in and dialogue with each other in responding to these. So I think we see somebody over here. We'll kind of go up, or maybe do you want to go those 3 back there? I don't know who's back. We've got Sonia, and then there's 2 in the back. Okay, go ahead.
Hi, excellent panel. Thank you very much. So this was actually the last thing that you talked about was where I was going. So in more physically stable settings or situations, faith-based or religious leaders have been very valuable communicators for health messages. Is that still the case in fragile settings where perhaps the physical space is less stable? And then my second question is, male involvement is really important in a lot of most settings. How is that addressed in fragile settings? Thank you.
Great, thank you. Sonia.
Yeah, I just wanted to follow up on that too. Again, thank you for this very interesting program. You've been kind of pussyfooting around the idea. We wouldn't have family planning issues if there weren't men. So, and men who want to have sex. So I just wonder, how you address that. And it seems that it happens at several levels. At the government level, I would assume that most of these governments are male dominated. Have you found female allies, the people who you can really work with to try to implement these programs? At the religious and ideological level, are there differences in different cultures? Have you found instances where men or male religious leaders or people are actually interfering in women having access to birth control and especially to abortion? Thinking about the U.S., that's certainly a huge issue here, and I would be surprised if it weren't in other places. Thank you.
Great, thank you. I think there's one more thing, Sarah.
Oh, and also HIV and STD testing.
Okay.
Hi, my name is Kate Onyejekwe from JSI. I just wanted to follow up on your question because you talked a lot about partnerships and collaboration and coordination. But what I heard most of the time was your partnership with the locals. And often in humanitarian settings and emergencies, there are other partners, other IPs and other agencies. And I wondered how you coordinate with them, rather not just how you coordinate with the local partners.
Great, that's a very good point. Nancy, I'm going to start with you. So for the whole panel, we've got sort of the role of faith and religious leaders. We've got the role of men in the government and generally, partnerships and collaboration amongst sort of a variety and different actors and overall, and then HIV and STD testing to bring it down to technical level. But Nancy, I want to start with you and get some of your thoughts on these.
So definitely religious men have a say and influence on our beneficiaries and communities and families, especially men. And we usually, whenever possible, try to involve them in our work. Even with the Ministry of Health, we usually have religious representative to ensure and disseminate messages that family planning is not something that you cannot do or it's prohibited. So usually in some communities, when it's really religiously driven, one of the root causes that preventing women from using family planning, we have to tackle this issue with other actors. So we have this kind of community awareness session where we have a religious representative from the Ministry of Health, and they would answer and discuss with the community all their issues and questions. And we found it in some settings, it's very, very beneficial. Male involvement, actually in acute setting, it's sometimes hard to involve them in the discussions, but we had this kind of pilot of hiring male community health, where they go to the places where men usually spend their time after work, and they start giving them health awareness messages and start a discussion about the barriers for family planning. We found this quite informative for us because we started to address the root causes for why men are refusing the use of family planning. Because sometimes the man is the one who decides whether the woman can access family planning services or not. We had to work on this. For the last question for local partners, yes, we work usually with local partners, but we have to coordinate and collaborate with other actors within the same area we are working. So for example, for Northwest Syria, we have the reproductive health working group led by FP. We have all the actors that are working in reproductive health. We try to unify our tools and materials, share knowledge. If we have a training, we can invite other organizations to attend this training. So we are trying hard to organize and collaborate and ensure that the efforts are becoming evident on our affected population.
So Erin, you want to jump in?
Yeah, sure. Great questions about religious leaders and male involvement. And I think involvement of both stakeholder groups is critical, and we do it in all of the countries that we work in. I think, thankfully, I think in family planning more generally, but also certainly in humanitarian settings, we've kind of overcome that off-cited objection around there being no demand. We know there's demand in every country in the world, in every setting in the world, no matter how conservative we perceive the social norms to be. That said, conservative social norms, just like in the US, anywhere, are something that we have to address when we're talking about any service that relates to women's sexuality, right? And so engaging with religious leaders and men is critical. And I think, it's not as difficult as I think many people might assume. A lot of what we talk about is the health of the family, the need for birth spacing, the burden of maternal mortality. These are all things that people see every day. Unlike in developed settings like in the US, everyone knows someone who died in childbirth. Everyone knows children who are spaced too close together, who are very malnourished. It's very in people's faces. And religious and community leaders and men care about their communities. They care about the women and children in their communities. And so this is the starting point and often the focus of the discussion. And we engage them often as community health workers, and they're also gatekeepers. I think there is a question around male involvement of how we can be gender transformative in that male involvement. I mean, I think there's still a lot of programming out there that's really, encouraging men to give their wives permission to use family planning, right? And that's not what we want. And so we've started, at IRC, we've started to attempt to address this by developing this curriculum we call Equal Partners for Healthy Choices, which is a gender transformative couples curriculum in which couples together go through a 16-week session, 3 hours each session, in which they explore gender norms and a lot of issues within the household, ultimately to improve joint decision-making around fertility and contraception. So we're excited about this as a possible avenue for kind of shifting that narrative around gender transformation. Oh, there's one great story from South Kivu I have to tell you guys related to the religious leaders. We've all been working in DRC for a very long time and so have strong relationships. And so there was this one priest who all of a sudden started preaching against long-acting reversible methods. And we saw this big increase in our implant removals. But we had been there so long and had such strong relationships with the community and community leaders that there was actually a backlash against the priest. And women and their husbands were saying, this priest is not going to take care of my child when I lose my job. And so I think we're going to keep our long-acting method. And so it was very interesting in terms of, just how much those norms had kind of shifted in favor of family planning based on the benefits that people had seen.
Jennifer, I want to kind of put this to you in a little bit different way, up at the sort of advocacy level, on top of coming back to sort of the male champions and that sort of piece, and sort of the number of men in the room or not, right, that sort of thing. But how are you looking at all of this too?
Specific on male involvement or just across the board on a few of these?
If we could continue with the male involvement and move across the board, that'd be great.
I think so. Great questions, all of them, and certainly some of the key issues that everybody grapples with in the humanitarian space. So I think that it's important to stress a couple points. Is that one, diversity of settings, diversity of context. Every place is different. There's not a one-size-fits-all response. So just to make sure that that's really clear, but then also diversity across the phases of engagement. So in a crisis response in the first 72 hours, things look quite different than they even look 3 weeks out, 4 months out, even if that all falls within a crisis response. And so the ways that you engage in that space can be quite different and varied. And so you'll hear those differences across partners. I say that because the points on faith leaders as well as male involvement touch on what can be done in crisis in different phases. And one of the reasons that it's so important to localize a response is because in emergency response where you don't have actors that have been longstanding in a country, you need the local partnership right from the start. And when you come in external, you're it's a blunt instrument. Like, you must have that in order for your response to be effective. And so just to acknowledge how critical it is that you have women's groups engaged, that you have faith leaders engaged, and they become your partners in the response, because otherwise you really cannot operate. And so when you have actors that have been there for a long time, those relationships are established, even if they're humanitarian actors. And so those networks and longstanding relationships exist, making those partnerships all the easier when that response rolls out. So I just think that's important for context. And then there was also a question on HIV testing that I just wanted to quickly touch on, as far as we're talking about family planning today, but family planning is a component of the minimum initial service package for reproductive health, which includes prevention and treatment for HIV, as well as preventing or working to reduce maternal death, and prevention and response to gender-based violence. So there's a number of standards that sit within that package, and that as a package is the crisis response. So I just think that's also important for context. For global advocacy, which is now getting to what you were trying to put to me, I think when we think about the global stage and then the work that we can do in each country, I think a lot of the work, when I think about this portfolio, is about bringing the right actors to the table to have the discussion pre-crisis and then in response. So, from if you were to walk into Mali today, or you were to walk into Chad today, do we have faith-based actors that can be better linked with the humanitarian actors that are likely to be part of the response, talking together, understanding the coordination mechanisms? Are the existing technical working groups on reproductive health, are they linked to who may be a potential humanitarian actor, and do they have those relationships? Because those are really difficult relationships to build in the response. So what can be done beforehand so that it will roll out with the level of engagement that I think all of you were touching on through your questions?
Absolutely. Samina, do you have anything to?
No, I think everyone covered it. Just to emphasize again on the coordination mechanism, the question you had of how do we come together as various players to coordinate. And Nancy touched on the reproductive health working group, so that coordination is also part of the minimum initial service package. Please definitely take the course online. It really covers all of this and really demonstrates how, we hope to be working and are working on reproductive health in emergencies. So the reproductive health working group is definitely an avenue where all the organizations, international, local, government agencies, all working in reproductive health convene and really develop a work plan on how to tackle SRH in that specific emergency. There's also in humanitarian settings a health cluster. So there's the cluster system that we work through, and the health cluster is usually led by a national government agency, usually the Ministry of Health, and then co-led by WHO or a UN partner. So there are those mechanisms that, just to bring in the wider coordination. And also to mention that donors have started to require that we work in consortiums as well, and require that these consortiums of international NGOs also have local partners to work with, which is a great idea, I think, in terms of just better resources, more minds on one piece of work, and further reach as well.
So we have one question that came in from Twitter from Natalie Rowthorne of Change. How has the global gag rule affected the implementation of family planning services in humanitarian settings?
So that's like the question of the hour, right? I think, there's a lot of amazing organizations, including Change, who are working to document the effects of PLIGA. I think we're not, from what I understand, and I'm not the authority on this by any means, this is more just my understanding, we're not there yet in terms of having the definitive data on, how many services have been lost, how many clinics have closed, how many women lack access. We know it's happening. We hear about people losing funding all the time. It affects humanitarian response, just like it affects development programming. At the IRC personally, we're a U.S.-based organization, and so we don't have to sign, and so that's one kind of benefit just of our structure. I think we are seeing increasing commitments from private and other bilateral donors to family planning and sexual reproductive health more generally, which is of course wonderful, and we want that. But we can't really overstate the importance of U.S. government funding in this space and how large the impact is of the global gag rule on women's health more broadly in the world. And I think we're all interested in seeing the data that's coming out of Guttmacher, Change, a lot of organizations who are doing great efforts to document this better. So hopefully that we don't see it in the future.
All right, let's go back to the audience. We'll do one here, and then we're going to go over there.
Hello, my name is Katie Graham with PATH, and I have two quick questions. The first is that within the SRH community, I think that we've all recognized the importance of addressing kind of the physical health outcomes of gender-based violence, but often the mental health outcomes are left behind. And so I'm wondering what any of your organizations are doing on mental health in general, but also really specifically how you're linking that to FP or GBB services. And the second question is that the root of all of this is really women's empowerment and recognizing that the structural barriers that exist during times of peace are heightened during times of conflict. And a lot of you talked about programming that seeks to shift gender norms. And I know, Jennifer, you just mentioned the importance of working with women's groups, but I'm wondering how you all are working with local women's organizations to build their advocacy capacity to ensure that they are at those humanitarian decision-making tables. So, for example, at the cluster meetings that Seema just mentioned.
Great. I thought, so one back here. And then we'll come to you right after.
Sorry. I just had a question. I know this keeps getting brought up, but in terms of norms and taboos, how do you tackle that on a larger scale, government, even U.S. level? I know we struggle with having these types of conversations even here in the U.S. So how do we tackle that to then, show the importance and how it should be prioritized in response?
Great, good question.
Hi, thank you. My name is Janet Fleischman with the CSIS Global Health Policy Center. Really great to see all of you up on the panel. You had mentioned the issue of the donors and particularly the U.S., and I wonder if you could unpack a little bit OFDA, PRM, USAID, Global Health, in terms of their support for the work on family planning and humanitarian crises. We know the U.S. has been the global leader on family planning and humanitarian response. Where does it fall in terms of the family planning piece? Thank you.
$1 million question. So Nancy, we're going to start with you again. So we've got sort of how are we all dealing with mental health? How are we looking at women's empowerment and advocacy, making sure women are at, I'll call them the decision-making tables, tackling norms and taboos at scale, and then unpacking the funding mechanisms. Nancy?
So regarding the SGBV response, so usually what we have been doing in Save the Children is trying to integrate with other projects, because usually donors are focused on like family planning, on a single intervention. So what we have been doing was integrating with our mental health and SGBV protection programs, where we can provide the medical services and the clinical treatment, and then would refer the cases to our protection programs, where they can work on the psychosocial support and other issues of the survivors. But this was like an approach that we took when we started working in family planning, and a lot of the community have various needs. It's not only HGBV or clinical needs, but they have other needs for education for their kids, for livelihoods. And we couldn't just speak to the family about family planning, despite it would solve a lot of their problem not to have further children, but they couldn't see it. So we had to integrate with all our programs to ensure that we are providing this comprehensive package of services, and not only a separate services or bits and pieces of the package. So this was our approach, and I think it was really beneficial. We gained the trust of the communities that we were working in at that time, and we saw a spike in the uptake of family planning after integrating with different sectors and subsectors in our work. The second question about the norms and taboos, and honestly, to change this on national level, you need like this kind of political will. We have seen this in some countries where we can work on advocacy and campaigning and tackling this kind of norms and issues, trying to shift the behaviors of the community and even of the service providers. But I think the main factor in this was the political or the national system will to actually induce this change on a larger scale.
Who wants to jump in? Seema, you want to jump in?
This was a hard round.
I know.
Yeah, I think all our agencies have protection teams, and so definitely, there's a very a close integration between our health programs and our protection programs, specifically when it comes to sexual and gender-based violence. Sometimes the divide a little bit is around that the health programs provide the clinical treatment to survivors of sexual violence. While the protection team are responsible for perhaps identifying survivors and then referring them to the health facilities that we work in. And then the loop back is after they've received the treatment to be, followed by psychosocial counselors that would work again within the protection team to offer a long-term support. I don't think mental health has really been unpacked in the way it can, even in conflicts that have probably that we would say has finished. I live in Liberia, and I still see a decade after its prolonged conflict, how that affects people even on a daily basis, and is exacerbated when there are major events like an election, for example. So I don't think we've really studied as a humanitarian community the real impacts of mental health. Gender norms, it's, I think we've all given some different examples. I think to me, gender norms is really about that dialogue piece and finding a way to negotiate whatever that starting point is, and to realize that that starting point is not the end point. So, just to give an example, in Cox's Bazar in Bangladesh, with the Rohingya refugees, the families, particularly the men in the household, were very concerned about their women and the girls leaving the tents, their camps, to go to health facilities for reproductive health services. They wanted them to go for these services, but feared for their security to be going, for them to walk to the clinics. And so we started to then provide those services in a mobile team approach, mobile health team approach. And so bringing the services to the community. And once they put a face to the services and, face to the providers, and really understood the kind of services that were being provided, they felt safer, and there was that trust. Trust definitely takes a long time to build, but once that was built, then we saw a huge uptake of clients coming to the health facility. So I feel like we just need to find what that middle ground is and have that dialogue very early on in the emergency. Good, Erin.
Yeah, sure. Just to kind of quickly add on the integration with women's protection and GBV and SRH services, IRC's been testing a pretty cool model in Nigeria and Bangladesh for comprehensive women's centers, which are basically a one-stop shop that are women-friendly spaces, gender-based violence case management and protection programming, as well as comprehensive sexual and reproductive health services. So anecdotally, they are going great. Women really appreciate these services. There are some challenges in ensuring that women's partners have access to the SRH services too, and things like that. But I think we're really interested in evaluating this model as a way to better integrate services. We also do a lot of mental health work in humanitarian settings more broadly, but I'm not qualified to talk about it right now. But just to say, to complement what Seema was saying around national level norms change, you start with the starting point where they're at, but you also link up with the efforts that are already happening. I mean, there isn't a country in the world that I've worked in where there isn't already an effort to broadly improve women's access to sexual and reproductive health services and improve gender norms. So for us, it's about finding those people who are doing that great work and helping them with their efforts, whether it be with financing or partnerships. I don't know if everyone in this room is aware, but, there was an amazing Nexus-wide effort in the DRC to change the abortion law, and it worked. And abortion is permitted in a wide range of circumstances in the DRC. This was an effort that linked up with what was already going on at the national level to implement the Maputo Protocol in country, that organizations were able to support to make that happen. And so that was really exciting. And, we have the question around unpacking the different streams of U.S. government funding that I feel like we're avoiding. But I, with the caveat that I lead our large anonymous donor project, so I'm not steeped in the U.S. government funding environment, even though the IRC works through U.S. government funding. It's a large donor for us. I certainly know that we're providing comprehensive family planning with U.S. government funds, OFDA, certainly. I mean, there is a little bit of a challenge, I know, that I don't totally understand the mechanism around purchasing contraceptives with OFDA funds. But in terms of supporting the broader programming, that's a part of our primary healthcare services that's OFDA funded. For USAID more broadly, of late, there have been a lot of business development efforts going on around Nexus-style consortia to increase access to family planning globally, kind of bringing together development and humanitarian partners to do that. So I think, and there's also research implementation science calls as well. So I think we're seeing a lot of that. And I think I personally, even if I'm a little bit of an outsider looking in because I don't focus on that donor, I'm very excited about the partnerships that those mechanisms have created, and I think we are going to see more of them in order to really answer this scale question. And so I'm excited that USAID has been putting forward these opportunities.
Great, Jennifer, we're going to give you the final.
Yeah, just a couple of final add-ons, I guess. So there was a question about kind of building capacity or advocacy capacity for women's groups and local organizations. And I think that is just to put forward that that's a great question. And it is something that I think a lot of the humanitarian agencies are thinking about, certainly at FP 2020. It's something that we're thinking about, when we look at the ecosystem we want to support, and we want to see more women's-led organizations part of the response or advocating for that, minimum standards within response, or youth-led organizations. That role of building their capacity is critical. And currently it is not always up to par on the humanitarian role. And so looking at what partnerships could be established so that can be developed. So a really good, important question, and I think an important consideration for all partners who are looking at localization more broadly. And then I just also let people know that I believe there's a couple organizations that are working on funding studies. So that should be out, I believe, by the end of the year, looking at kind of tracking family planning dollars from different donors that should be very enlightening for all of us to better understand how much is going to what and from whom.
And it's always that getting the emergency funding and the development funding more aligned, which is always the argument I make. I'm not successful yet, but... So I want to ask all of you to give a big hand for this entire panel and for all of your insights. I think that, the takeaways, as I think we started with, were this works. We can do this in these varieties and types of conflicts, not to minimize the importance of finance. And I think Erin's point about sort of like when it's rapid onset and it's the first 72 hours, there's a lot that needs to be sort of on the ground and mobilized. But the partnership piece, and I like how we've just sort of up to the donors and back down to the governments and local actors, and the coordination, which is part of, I think, what was intended today, which was to bring us all together to showcase that it can be done and to talk about the coordination that's going on the ground. Seema started off with, I've been working with these other NGOs, and I worked in primary health consortiums with, 5 to 8 of us. And so that's incredibly important. So thank you, and thank you all, and have a great day, and thank you for coming to the Wilson Center.